afternoon, everyone. Welcome to this EDTNA ERCA webinar on how to promote psychosocial well-being for patients on hemodialysis using arts.
My name is Jeanette Finnerup, and I'm a scientific board member of the EDTNA ERCA, and I will moderate this session for you. And then I'm very honored to introduce today's speaker, Dr. Claire Caswell. She's a registered mental health nurse and recently completed her PhD at the School of Nursing and Midwifery at Queen's University, Belfast. Her PhD focused on the development and feasibility testing of an art-based intervention for patients with end-stage kidney disease. Her primary research interests relate to the relationship between kidney disease and mental health, the evaluation on complex intervention, and promoting patient and public involvement in research. I sincerely hope that you will get the most from this webinar. Now I'm passing the mic to Claire Caswell.
Thank you so much, Jeanette. And thank you so much to the EDTNA for having me here today to discuss this topic. And thank you for everyone who's taken the time out today to come and find out more about using art to improve the mental health and well-being of patients on hemodialysis. Now, just to give you a quick overview about what I'm going to cover in the webinar today, the first thing I want to discuss is the problem of mental health and mental well-being for patients receiving hemodialysis, because it's quite a big unaddressed issue for these patients. The second thing that I want to discuss is how art theoretically could help improve these issues that patients on hemodialysis are experiencing. Then I'm going to tell you a little bit about my experience delivering art in a hemodialysis setting and some of the practical issues that we had to take into consideration. Then I'm going to discuss a little bit about the findings from my PhD project that provide a little bit of evidence about how art could improve mental well-being. And then finally, I'm going to give a bit of an overview about where further research is needed. And then at the end, we should have some time for questions. So, as I'm sure you're all very aware, hemodialysis is an incredibly difficult and time-consuming treatment. Patients have to attend hospital 3 times a week for 4 hours each time, and during that time they're connected up to a dialysis machine. They're restricted to either a bed or a chair, and they have very little opportunity to engage in meaningful activity. I mean, if you think about it, if you have experience from hemodialysis settings, what do people undergoing hemodialysis usually spend that time doing? For me, what I saw was they spent most of that time sleeping, maybe watching TV if they had a TV to watch, reading a book if they can manage that, or maybe playing Sudoku or a crossword puzzle. But the most time that people spend on hemodialysis is spent watching the clock countdown, waiting for the end of their treatment. But that's not the only time that patients dedicate to this treatment. They have to spend time waiting to go on the machine. They have to spend time waiting to come off the machine. They have to spend time waiting for transport home. They have to spend time going to and from the dialysis unit. And then usually by the time they get home, they're so exhausted and drained that they have no energy to do anything except for rest or sleep. So while the treatment itself might last 4 hours, they lose an entire day to hemodialysis, and that's 3 times a week, every week, potentially for the rest of their life. So this has a huge impact on their mental health and their mental well-being. And unsurprisingly, patients receiving hemodialysis are at a significantly increased risk for developing mental health issues such as depression. And depression is highly prevalent amongst patients on hemodialysis. In fact, a cross-sectional study by Kokoska et al. In 2016 found that of the patients that they sampled, 78.5% of them met the diagnostic criteria for some form of depressive disorder. This ranged from dysthymia to a major depressive episode. Now, generally, the literature does put the prevalence of depression between 25 to 50%, but that's 1 in 2 dialysis patients with depression. And that is significantly higher than the general population, where the prevalence of depression is about 4%. However, even those figures have to be taken with a pinch of salt because depression is notoriously under-recognized and underdiagnosed in patients on hemodialysis. And this is for a number of different reasons, but the main problem is the problem of uremia. If you don't know, uremia is the buildup of urea, which is a waste product in the blood, and patients who have kidney disease tend to develop uremia because their kidneys can't excrete it. And whenever patients present to primary care with depression, they overwhelmingly report somatic symptoms of depression, like a loss of appetite, an inability to sleep, a loss of sex drive, problems concentrating, problems with their memory. And those hallmark symptoms of depression are identical to the hallmark symptoms of uremia, which means that the clinical presentation of kidney disease actually masks the clinical presentation of depression. And then there's the problem that if you do manage to get a diagnosis of depression, you're not likely to get treatment. In fact, another cross-sectional study by Warwick et al. Found that of patients who had a diagnosis of depression, only 16% of them were receiving some form of treatment for that depression. And again, there are multiple different reasons why this happens. Mostly because we don't actually have any good evidence for what helps depression in patients receiving hemodialysis. For example, antidepressant medication, which is incredibly effective in the general population, isn't effective in patients receiving hemodialysis. A recent randomized controlled trial found that sertraline, which is a selective serotonin reuptake inhibitor, a type of antidepressant, was no more effective in patients receiving hemodialysis than a placebo, but it had a huge amount of side effects and a lot of serious adverse events. Additionally, even the non-psychopharmacological interventions, for example, psychological therapies like CBT, cognitive behavioral therapy, which are very effective in the general population, aren't as effective for patients receiving hemodialysis. And one of the problems is the treatment burden that patients receiving hemodialysis are already under. So if you think about CBT, CBT requires patients to attend an appointment each week. They have to have the energy and the concentration to engage with that appointment, and then they have to have the energy and the time to do homework in between appointments. So for patients who are already in hospital 3 times a week, who are exhausted and who have limited time, interventions like that just aren't feasible or acceptable. So there is this unaddressed need here for patients, and this requirement for us to come up with holistic ways to address the underlying issues that are contributing to poor mental health. And one of those ways could be arts-based interventions. Now, I just want to clarify what I mean when I say arts-based interventions, because there are some terms that people use that normally get very confused. So whenever I say arts-based intervention, what I mean is the use of art in a healthcare context for the purpose of creativity and enjoyment. It is not art therapy. This is because it is not carried out by a trained arts therapist. It's not carried out within a psychotherapeutic framework. And it's not actually carried out to meet a clinical objective. Art therapy tries to treat mental illness. Arts-based intervention doesn't. What it's trying to do is create personal enjoyment with arts activities. But they might be ideally placed to address the fundamental problems that contribute to poor mental health that patients receiving hemodialysis are experiencing. And I just want to discuss 3 core theories that relate to why art might be best placed to address these different problems. The first theory I want to mention is the theory of existential boredom. The term existential boredom was first used by Aoife Moran in 2009 in relation to hemodialysis to describe the experience that patients had while they were on the machine. And I think that whenever we think about boredom, it can seem almost trivial, but this type of boredom has a profound impact on a person's state of mind. When people are in hemodialysis, they have very little to do. They have no meaningful activity to engage in. This means they're profoundly bored. And when you're profoundly bored to that degree, that often, and for that length of time, you start to think about time. You start to think about the passage of time. And this naturally leads you to think about things like mortality and illness and death. And these are patients who are in a clinical setting, who have an end-stage illness, and who are receiving a life-sustaining treatment. So they're already primed to experience those intrusive negative thoughts. So it's not surprising then that they experience existential boredom whenever they are on the machine. So whenever I say that art can help reduce boredom, that might seem trivial, but that has a significant chance of improving someone's mental health in this situation. The next theory I want to talk about is the theory of flow. Now, the theory of flow is very closely tied to art because the theory was developed by a positive psychologist called Tachy Psychia after he was watching artists at work. And flow is about a state of optimal engagement, of complete absorption in an activity. And when you're in that absorbed state, it's called a flow state. And when you're in that state, you stop paying attention to everything around you. You stop thinking, you stop worrying. You're just completely focused on the task at hand. And that, in relation to existential boredom, could be incredibly beneficial for patients on hemodialysis because it stops them experiencing those intrusive negative thoughts because they're so focused on the moment. However, another aspect of flow is an experience called Tachy Psychia, which is an altered perception of time. Most typically, people experience time passing a lot quicker than it actually is. And the majority of patients on hemodialysis will describe time dragging, that they have to watch the clock count down. So the fact that we speed this up for them, that they don't have to count down, could again be very, very beneficial. And then the third theory that I want to talk about is called PERMA, and it's a theory related to mental well-being, which is a slightly different concept to mental health. Now, I am going to discuss it in more detail in relation to art whenever I discuss the findings from our feasibility study, but I just want to talk about it for a bit in relation to hemodialysis, because I think when you contextualize PERMA within hemodialysis, it's quite clear how negative hemodialysis can be for someone's mental well-being. So when you think about PERMA relates to 5 constructs that are thought to be essential for good mental well-being. The first construct, the P in PERMA, stands for positive affect. Positive affect is just another term for happiness, so positive emotions that people are feeling. And I want you to think about for a second, what makes you happy? What makes you feel enjoyment and contentment in your day-to-day life? And how does that contribute to your mental well-being? The E then in PERMA stands for engagement, and this is directly related to flow states. So the idea is that you need to have opportunities to enter into flow states in your day-to-day life in order to feel this level of engagement and have good mental well-being. So this could be things like hobbies, it could be things like your work, but just have a think about, where do you find that level of engagement in your life? Where do you find that? Where do you have that opportunity to enter into a flow state? The third component then are relationships, because human beings are inherently social. We like to be around people. And they can be many different types of relationships that contribute to good mental well-being. It could be your family, it could be your friends, it could be your spouse, it could be your children. But we need a different variety of close, good relationships to contribute to good mental well-being. So have a think about what different types of relationships you have in your life and how those contribute to your mental well-being. The M in PERMA then stands for meaning. And this is about having a reason to get up in the morning, having purpose in your daily life, a reason to be doing the things that you do. And you can find this again in multiple different places. It could be your hobbies, it could be your relationships, it could be the work that you do. But have a think about where in your life you find that meaning. And then the final component, which is A, is achievement. And this specifically relates to the need for human beings to develop, to learn and develop new skills and be constantly achieving new things. That contributes to our mental well-being. So again, just think about, where in your life do you find achievement? Where in your life do you feel like you have an opportunity to develop and improve? And now I just want to think about how all those different components can be impacted by having your kidneys fail and having to go on hemodialysis. Maybe you will have less opportunities to experience happiness and enjoyment and contentment because you will be so preoccupied with the end-stage disease that you're dealing with. You'll maybe not be able to engage with your hobbies as well. You maybe won't be able to work like you used to, and that will impact your opportunities for engagement. Your relationships could change because you maybe can't spend time with your friends like you used to. You might not see your co-workers as much because you're not going into work. Your family dynamics might change because maybe you were once the care provider and now someone has to care for you. And then with meaning, a lot of your life might get taken over by the fact that you're just trying to stay alive. You're just trying to get treatment for your disease. And sometimes it can feel like you're living to dialyze. And then finally, achievement. You might not feel like you're growing. You might not feel like you have the opportunity to develop like you used to, because your time again is spent doing these different treatments. And so you don't get the opportunity to learn and develop new skills. So I think it's quite clear how negatively hemodialysis treatment and end-stage kidney disease can impact mental well-being. I'm now going to shift and talk a little bit about the feasibility study that we did as part of my PhD project, because it gives you a good idea about how this can practically be done. So the PhD project involved a feasibility study, and all a feasibility study is asking whether or not it is possible to do something. So the main questions we were asking is it possible to bring art into a hemodialysis unit? And is it possible to evaluate the effect of that arts-based intervention through a randomized control trial? So we conducted a pilot cluster randomized control trial to look at the feasibility of delivering the intervention that way and evaluating it in that way. But we also conducted a process evaluation. And a process evaluation focuses on how you are doing things and how things might work. And we also wanted to see whether patients and healthcare professionals thought the intervention was acceptable. Because even if it's possible to do something, it doesn't mean people are going to like it. So we had to check that out as well. I'm going to quickly describe what the arts-based intervention actually looked like so you understand the context of some of the difficulties that we might have come up against. So the intervention that we developed involved 6 one-hour-long, one-to-one facilitated art sessions at the patient's bedside during hemodialysis. And these sessions happened twice a week over a period of 3 weeks. Every participant got their own individual arts pack. So this meant that they could take their art material home at the end of the intervention, but also meant that there was no sharing of materials between participants. So there was no risk of cross-contamination. And then participants could choose between either visual arts or creative writing. They could choose between different types of visual art and different types of creative writing. And they could choose any subject matter that they wanted to draw or write about, or they could select from a series of prompts. Now, each session focused on skill development. And this was because we wanted to induce a flow state. And in order to induce a flow state, the activity that you're doing actually has to be a bit difficult. It has to be challenging. But you also have to develop the skills to meet that challenge. So we wanted this to be a little bit difficult for participants, but we wanted to show them how they could meet the challenge that we were giving them. Now, this intervention was developed in collaboration with patients and with healthcare professionals because we knew that we needed to identify all of the practical barriers that we could face going into a hemodialysis unit to deliver this intervention. And there were 3 key concerns that came up during that development process. The first one was obviously infection control. So we wanted to make sure that we weren't increasing the infection risk for participants and that we could do this within all infection control protocols. Now, I'm mindful that this study took place between 2018 and 2019, so we weren't dealing with the pandemic or those sort of enhanced infection control issues. It was how it was before the pandemic hit. Now, the second issue that we had to take into consideration was arterial venous fistulas. I'm assuming that most people here know what an AVF is, but just in case, an arterial venous fistula is whenever a vein and an artery are connected in a person's arm. This causes the blood vessel to balloon up, and this allows repeated needling for the vascular access required for hemodialysis. Now, we had to be careful about this because if a person moved their arm and dislodged a needle, that's a life-threatening event. But we also had to be careful because patients might be fine not wanting to move one of their arms, but they might not feel comfortable painting or drawing or writing with their other hand, with only one hand. So we had to make sure that we'd taken that into consideration and figured out how to make it accessible for people who had AVFs. And then the last concern was to do with the energy of the patients. Like I mentioned earlier, a lot of patients spend time on hemodialysis sleeping, and that is usually because they're exhausted. Patients receiving hemodialysis experience profound fatigue. So a lot of healthcare professionals that we spoke to were actually worried that patients just wouldn't have the energy to engage with this. Now, we were able to address most of these issues prior to starting the intervention, but we did manage to encounter quite extreme circumstances of each of these that I want to tell you a little bit about, to give you an idea about how adaptable patients and healthcare professionals are whenever we're trying to deliver this sort of intervention. So in terms of infection control, like I've mentioned already, each participant had their own individual ARTS pack, so we didn't really have to worry about cross-contamination with sharing resources. However, one participant became very unwell prior to receiving the intervention, so they contracted a very serious infection before they started the intervention. So it wasn't the intervention that gave them the infection, but this meant that they were hospitalized and that they had to receive hemodialysis in an isolation room with enhanced infection control procedures. And the first step, obviously, whenever this happened, was to check that the patient was happy to continue in the study and that the healthcare professionals were comfortable with me, because I was the person facilitating this intervention, that they were comfortable with me going in to the isolation room to deliver this intervention. And the healthcare professionals on the unit, their attitude was, well, if we can go in there, you can go in there. And I mean, I was up for it as well, and the patient was very happy to continue, so it wasn't an issue. It did mean that I had to wear the full personal protective equipment, so the gloves, the apron, the face mask, the visor, and that was fine, except for the fact that my glasses kept fogging up, but you can work through that, no problem. The other thing was that I couldn't bring anything into the room that I would then want to take out again, because this was a highly contagious infection. So the participant had to keep their ARTS pack with them at all times. Like I said, they were hospitalized, so they kept it on their bed, which meant that it only moved with them whenever they were transferred up to the ward. It was never stored anywhere on site. It was kept with them at all times. I also couldn't bring in anything like reference images or my own sketchbook, just in case. But again, that was very easy to adapt to. It was no reason why we couldn't do it that way. The next thing I want to mention is the arterial venous fistulas. The majority of people who have an AVF, they have an AVF placed in their non-dominant hand. So for example, if you are right-handed, the surgeon tends to try to put the AVF in your left arm so that you have your right hand free. That was the case for most of the participants, and they did not mind painting one-handed. Like I said, it was one-to-one facilitation at the bedside. So I was there next to them, helping them, use all of the materials. So practically they were supported, and that worked absolutely fine. We did have one participant though who had their AVF in their right arm, and they were right-handed, and they were completely up to the challenge of painting left-handed. And again, because I was there next to them, this wasn't an issue. They were very comfortable doing it. I was there to help them with the materials. But what I did find was that they were actually a lot kinder to themselves than most of the other participants. And I think this was because no matter how their art turned out, they always saw it within the frame of, I did that left-handed. So it felt like more of a challenge. And whenever they were able to create something, no matter how it looked, they thought it was great. So it was almost a positive as opposed to a negative. And then the last issue was energy and fatigue. Now, as I mentioned, one of our participants was incredibly unwell, the person who contracted that infection and had to be hospitalized. And because they had an infection and because they were hospitalized and receiving hemodialysis and had end-stage kidney disease, they were exhausted. They were absolutely exhausted. They were experiencing very intense fatigue. to the point that they were literally falling asleep while they were painting. Now, whenever that happened, my automatic assumption was that they were too tired to continue, and I would offer them to stop and that we would pick this up the next time they were on hemodialysis. But every time I offered them that option, they refused, they wanted to continue, and instead all they asked was that I nudge them gently awake, and they would wake up like nothing had happened and just continue painting. So patients are incredibly adaptable. But I think it's important to contextualize that within what this patient was experiencing, because this was someone who was very unwell, but they were hospitalized. So this meant that not only did they have that empty time on dialysis, but once that was over, they were just going back up to a hospital ward. So this arts-based intervention was the only opportunity they were getting to do something different, to do something that was enjoyable. And they were not going to waste a minute of that if it could be helped. And these are just some examples of the art that the participants created. And one of the things that I found quite interesting, sort of coming at this from a more artistic perspective, is that whenever we were developing the intervention, another concern that a lot of healthcare professionals had was that people would be intimidated by a blank page, that they wouldn't know what they wanted to do, because a lot of the intervention involved personal choice. We wanted people to choose the type of art they wanted to do, as well as the subject matter that they wanted to focus on. And a few healthcare professionals thought that that would be too anxiety inducing for patients and they wouldn't want to do it. But what I found was that as the sessions went on, participants relied on prompts less and less, and they were able to identify things that they were interested in drawing or interested in painting or writing about. And some of it was just a general interest that they had, and some things were a bit more personal. So on this screen here, I don't know if you can see my mouse, but only 2 of these were prompts. The rest of them were all subject matter that participants actually decided that they wanted to create themselves. That they said, can you find reference images for these? I want to paint this, or I want to draw this. And I mean, I know I'm a bit biased because I was the one facilitating this, but I'm quite impressed at how quickly their skills developed as well. So for example, I love how the participant has the shading done in those huts and the bark on those trees and the highlight on that apple. You can see, like, you could see over time how much their skills were developing, and it was lovely. Now I'm just going to very quickly discuss the process evaluation. So a process evaluation involved 22 semi-structured interviews with both patients and healthcare professionals. And they were exploring their experience of the intervention, both in terms of taking part, but also what it was like for nurses to have it there on their unit. And we were able to identify 4 overarching themes from these interviews. The first theme related to the perception of art participation. This was both before, during, and after the intervention, because it did change over time. So for example, a lot of participants reported that before they started taking part in the intervention, they had no experience with art and they were quite anxious. There is something about art and drawing in particular that makes people incredibly anxious, and a lot of people are convinced that they can't do it, but they can. So people had this almost negative perception going forward. They were bored enough that they wanted to try it, but they had this anticipation that they weren't going to be very good at it. Then while they were participating in it, what they found was actually they could do it, and they were almost pleasantly surprised that they had the ability within them. They were still highly, highly critical about the art that they produced though, and I think that's common to everyone. We are all our own worst critics, and part of that problem was the fact that their only point of comparison was me, and I'm not an artist, but I've been practicing art for a lot longer, so there was a lot of reassurance going on in the intervention in terms of, you're only starting, you've done this twice, you're doing great. The second theme then was relating to the acceptability of the arts-based intervention. So this was whether or not the design of it and how it was delivered was acceptable both for patients and for healthcare professionals. Overwhelmingly, everyone thought it was acceptable. And the only criticism people had of this intervention was the length of it. They didn't think it was long enough. Participants wanted a lot more sessions, and they wanted the individual sessions to be longer, and so did the healthcare professionals. And this has actually resulted in some new work that I'm going to talk about later. We then discussed the acceptability of research procedures as well, and we found that the design of the intervention and the design of how we were going to evaluate it was acceptable. So for anyone who's not familiar with the methodology, a randomized controlled trial involves randomizing people to either receive the intervention or not receive the intervention. In this situation, we used a waiting list control design, so everyone who was randomized not to receive the intervention was going to at the end of the study anyway. What we found was that that initial anxiety that participants had, that they weren't going to be good at art, lent itself really well to that randomized control design, because participants who were allocated to the waiting list control group were almost relieved that they didn't have to participate in art straight away. So it was a lot more acceptable than we thought it was going to be. And then the effect of the arts-based intervention on patients and healthcare professionals. I'm going to go into this theme in a lot more detail because it speaks to the effect that the arts-based intervention could potentially have on patients' mental health and well-being. And there were a lot of quite surprising benefits that I hadn't anticipated seeing in patients and in healthcare professionals. So the first sub-theme that I want to talk about is the generation of positive affect due to exposure to the arts-based intervention. So again, all positive affect means is positive emotion. So patients who took part in the intervention, they felt happy, they really enjoyed it, they felt content, and it actually helped relax a few patients as well, which is reassuring considering how anxious a lot of them were at the start of the intervention. So for example, one participant said, "Very relaxed and away from me. Well, not leaving all my worries behind, but just sort of made me a lot more relaxed than what I would be." Healthcare professionals also noticed that patients were incredibly happy when they were participating in this study and that they were enjoying the intervention they were engaging in. So for example, one healthcare professional said you could just see their whole face light up and just expressing how they did it and how they enjoyed it. So it was almost a benefit to healthcare professionals to see how happy patients were while they were on dialysis. The second sub-theme then was an improved self-esteem. Like I mentioned before, the majority of participants who took part in this study hadn't done art since they were a child, and they didn't think that they would be very good at it. Also, the majority of participants were in their 60s, 70s, or 80s. I think the mean age of participants was 78. So these weren't young people taking part. This was the older generation taking part. And I think there's that mindset of you can't teach an old dog new tricks, that people just didn't think they were going to be able to pick up these skills, but they could. So one participant said, just doing it was enough to let you see that you were capable of doing something, you know? So patients had almost written themselves off, but then by participating in this, they had this new sense of confidence that they could do something new. Healthcare professionals also noticed this improvement in confidence, and they could see that patients were developing their skills as they were going along, and that they were actively contradicting the negative self-thoughts that they had at the start of the program. So for example, one healthcare professional said, "I would say a lot of people who didn't think they were arty got onto it, and they were rather pleased that now they wouldn't be a bit scared about lifting up a pen and pencil and drawing something, you know?" So that was really reassuring, that it wasn't just this subjective sense of self-esteem, but healthcare professionals actually saw this being translated into patients' behaviours. The next sub-theme that we found was that patients developed a sense of purpose. Like I mentioned earlier, a lot of people on hemodialysis can experience a loss of this sense of purpose. They can feel like they are living to dialyze, and that is the meaning that they have in their life. It is just to go and get their treatment. However, this intervention gave them not just something to do, but something to work towards, and something that gave them a reason for attending dialysis that wasn't just dialysis, if that makes sense. So for example, one participant said, "It gave me something to go for, like a goal. Give me a goal to go for. You go for that and you keep going for it. So they had a purpose to work towards. Healthcare professionals, again, notice this in patients, and very interestingly, they noticed this in the attitudes that patients had prior to starting their hemodialysis treatment. And they noticed this particularly out in the waiting room. And I do remember one healthcare professional saying that it almost made it easier to get people in and on the machine because this was what they wanted to do. So they were excited to be going to hemodialysis because they got to take part in this. So for example, one healthcare professional said, well, you could see a difference in the patients just in the reception area by them talking about, oh, what did you do the last day? What are you going to do today? And you could see the excitement in them. They were looking forward nearly to come to see what they were going to do and see what they were going to learn. The next sub-theme was one that I was particularly surprised by, which was an increase in social interaction. Now, for a lot of participants, they find that hemodialysis is a very lonely experience, even though a lot of people experience dialysis in bays where maybe there are other patients opposite them. They're still restricted to a bed and they don't really get the opportunity to chat to other people, except for maybe in the waiting area or if they're quite friendly to the people next to them. And then for people who have other disabilities, or if they're being nursed in isolation, they're even more cut off from the rest of the unit. So undergoing hemodialysis is very isolating. As a result of that, one of the benefits that patients reported was that they had that one-to-one facilitation. So I was there the entire hour, providing them with instructions on how to use the materials and advice on how to develop their skills, but that was also added company. So they had someone to talk to other than just being alone. So for example, one participant said there was somebody there to talk to. The talking to was just as good as the art. Well, it's just, I love the company of the facilitator. The company made a great difference. Now, this was something that I think is quite easy to anticipate from the arts-based intervention. But what we found was that the increase in social interaction went beyond just the facilitator and participant relationship. In particular, healthcare professionals noticed this. Healthcare professionals reported that patients who'd previously never spoken to each other, who hadn't been close, were starting to strike up conversations in the waiting area because they suddenly had this common interest. They were both in this study and they were both doing this intervention. So it was bringing patients together because they had this common experience. However, it also improved communication between patients and healthcare professionals. We were worried going in that the intervention would in some way impede healthcare professionals' practice, that it would get in their way, it would get under their feet, or it would make it more difficult for them to do their job. So we were worried that it was actually going to be a barrier to communication. But what we found was that it actually improved the relationships between patients and healthcare professionals because they suddenly had this topic of conversation that had nothing to do with disease or treatment. So for example, one healthcare professional said they were more chatty afterwards. They were a very closed little book beforehand, but then once they started to do this and you asked about it, then they kind of opened up to you. You learned a lot more about the patients. So this actually improved relationships just outside of the basic fact that there was a facilitator there, and that was something I genuinely hadn't expected. And then the final sub-theme relating to this overarching theme was the positive impact of the arts-based intervention on the dialysis experience. Now, like I said, we were trying to induce a flow state in these participants. We did want to improve the dialysis experience that way, and that is what the intervention was designed to do. So I wasn't surprised, and it was quite reassuring to see that patients were reporting that it did distract them from negative intrusive thoughts, that it did help speed up the time, that it occupied them, it stopped them from being bored. So for example, one participant said, you were doing something with your hands. You were focusing on trying to do this well because it was doing something instead of just lying, thinking about different things. Your mind just goes, you go from one thing to another type of thing, you know, thinking back to the past. And I think that highlights what an issue time on dialysis can be in terms of that existential boredom, the fact that people do ruminate, people do find it difficult to take their mind off those intrusive negative thoughts, but art was able to help with that. However, this wasn't the only impact that we had on the dialysis experience. Healthcare professionals found that it actually benefited their own experience of providing care on dialysis as well, that the provision of art in this highly clinical setting made it feel a lot less clinical and a lot more human. But what was interesting was that whenever I was providing this arts-based intervention and talking to healthcare professionals on the unit, a lot of them are acutely aware that patients struggle with time on dialysis, that this does profoundly impact negatively their mental health and their well-being. And there's this sense that healthcare professionals and nurses and healthcare assistants don't have the time or the resources to address that need. They're aware that need is there, but they can't meet it, and that causes some level of distress. However, having this almost seemed to benefit them by addressing that need, making sure that they didn't feel like they were neglecting patients in any way. So for example, one participant said this was sort of taking it to the next level and saying, it's not all about dialysis, it's not all about kidneys here. We're looking after you and we are seeing what can benefit you positively here. So they could see how they were providing holistic care instead of a medicalized model, and that was beneficial for them. So there were a lot of unanticipated benefits to this arts-based intervention. I was expecting and hoping that we would induce flow states, that we would help patients pass the time, reduce that negative thinking that they can be prone to while on dialysis, and improve mental health that way. However, once we analysed the data and we had all of those effects of the arts-based intervention, we realized that the benefits were a lot more broad and they impacted a lot more people than flow on its own would account for. And that's whenever we identified the model of PERMA, the model of mental well-being, as being the most appropriate for an arts-based intervention to explain the benefits that patients and healthcare professionals were experiencing. So for example, positive affect. Patients reported that they really enjoyed this intervention and they felt more happy, and healthcare professionals were able to observe that effective response on patients' faces, and that made them feel happy. Engagement. Patients reported all of these subjective experiences of being in a flow state. They experienced the passage of time a lot quicker, that distraction from negative thoughts. So they had that opportunity for engagement. Relationships. Not only did they establish a new relationship with a facilitator that was not clinical in nature, it was very collaborative, it was very friendly, as opposed to treating a condition. They were also able to develop relationships that they already had with other patients and with healthcare professionals. And healthcare professionals found that their relationships with patients improved as well. Meaning, patients had a reason to attend dialysis that wasn't dialysis. And I think that in itself was hugely beneficial. And they had this sense of purpose to their days. In fact, something that I noticed as well was that they had an increased drive, like an increased sense of volition is what you call that inner motivation that people can get. And one participant said that because they were taking part in the study and because they were doing the art, they felt motivated a lot more. So they started to pick up other hobbies that they'd previously stopped doing whenever they started dialysis. So we were actually having an impact on that sense of purpose and motivation outside of the dialysis unit. And then achievement. People were learning a brand new skill, their self-esteem was improving, and they were attaining new different goals. So I think that PERMA maps beautifully onto the impact of this arts-based intervention and can definitely capture the potential benefits that we can bring to participants on dialysis. Now, I don't want to insinuate that we have a huge evidence base to support this. And I also want to clarify that mental well-being and mental health are two different constructs. So for example, you can have very good mental well-being, you can have all of these components addressed, you can have positive affect, engagement, good relationships, meaning, achievement, and you can have a diagnosed mental illness. So for example, if you have schizophrenia, You can be diagnosed with that, you can be managing it, you can be experiencing some symptoms, so you can be mentally ill, but you can also have very good mental well-being. Alternatively, you can have very low mental well-being, so not very happy, no opportunities for engagement, very poor relationships. Maybe you feel a lack of purpose, you're not feeling like you're achieving anything, and you cannot have a diagnosed mental illness. You can be technically mentally healthy, but have very poor mental well-being. So they're not identical constructs, but they are very closely linked. So for example, I would argue that if you have very low mental well-being, you are at risk, if not currently experiencing, a depressive episode. And it's very difficult for someone who has severe mental illness that isn't very well controlled to also have good mental well-being. So by addressing mental well-being, we can have an impact on mental health, but it's slightly different to treating a mental health issue or a mental illness. So I just want to clarify that. Also, there are significant gaps in the evidence base for these sort of interventions. So like I said, I don't want to imply that we have robust evidence for the use of these interventions. We don't. This is an incredibly under-researched area. In particular, we don't have any evidence that actually shows these interventions are going to have an impact on mental health and mental well-being. What we do have is research that implies or suggests that we could have an impact on mental health and mental well-being. We have qualitative research, we have observational research, but we don't have any research that provides that causal link. And that's quite a big issue, because we need to establish, if there will be an effect, that there is an effect in order to justify the provision of these sort of interventions in practice. The next gap in the evidence that I want to mention is that even though we don't have the evidence for this, this is still happening in practice. There are still people providing art to patients on hemodialysis across the world without a robust evidence base. For example, here in Northern Ireland, there is a voluntary organisation called Arts Care Northern Ireland, who were very involved in this project, who provide art on dialysis at the Belfast City Hospital. And there are different organisations throughout the UK, throughout the world, that are providing arts and health interventions. However, they're usually provided by voluntary organisations, so charities, as opposed to within the healthcare system. As a result, we actually don't know what is going on and where it is happening. It's not joined up. We have no idea what people are doing in practice. So there is a need to explore that, to do some sort of scoping research to find out what is being done, so that we can establish best practice, that we can figure out what works in what circumstances, and collaborate and develop a way to join this up and improve access to arts on dialysis. And then the last big gap that I find that we have in relation to mental well-being and mental health for patients receiving hemodialysis is that we're not really researching alternative psychosocial interventions. Arts-based interventions are an option. And as much as I love art, and as much as I love this intervention, I'm not biased enough to think that this is going to work for everyone and everyone is going to take part in something like this, because that's unrealistic. It's not. Some people, it's not going to be their cup of tea, and for some people it will be too anxiety inducing to take part in. However, that doesn't mean that they don't need to address these different issues that we're trying to address with this intervention. And a lot of the research that is currently going on in relation to mental health and mental well-being for patients on hemodialysis is taking that more clinical, medicalized focus, looking at standard antidepressant medication or standard psychotherapeutic interventions that haven't worked in the past, that we don't have an established evidence base for with these patients. And I think in part the reason why they may not be working for patients is because of the very complex picture of end-stage kidney disease, the treatment burden, the symptom burden, and that those might be the issues we need to address to improve mental health and well-being, as opposed to treating it like a typical depression someone in the general population would develop. So we need to explore alternatives. We need to find what other people think will work. So for example, with this arts-based intervention study, this was developed in collaboration with the Renal Arts Group at Queen's University Belfast. And it was developed because the co-chair of the Renal Arts Group, William Johnson, is a kidney patient. He was on hemodialysis for years, and he coped by writing plays and writing poetry and engaging in the arts. So by linking in with patients, exploring what strategies they're using to cope, what they think will benefit other people, we could come up with alternative psychosocial interventions that are beneficial for everyone, or will give us enough of a variety to address this unmet need. And that leads me into what is next in terms of what we are doing, both in terms of RAG and this specific feasibility study. So this is going to be a two-pronged approach. We are going to both try to address the issues in research, but we also do want to make changes in practice. The biggest reason why we want to make changes in practice is because this feasibility study was conducted on a hemodialysis unit in Northern Ireland that had never had an arts presence on it. So patients there had never experienced this sort of arts-based intervention. Very few of them had much experience in arts. So they didn't really feel the need or the desire for it to be there. Then we delivered it and the study stopped and they wanted it. So we'd essentially created a demand for something and then we took it away, which isn't good. That wasn't our intention. And both healthcare professionals and patients wanted it back. So we had this almost urgent need to develop a strategy to get the art back into the unit without a research project in place. And we had different strategies going forward to how we could achieve this, but two of the findings from the feasibility study has informed our actual decision on how we're going to do that. And this is in relation to the length of the intervention. So like I mentioned before, patients wanted the intervention to be longer, they wanted more sessions. And actually patients and healthcare professionals felt that this should be available at all times. It shouldn't be time limited, it should be in practice. Patients should be able to participate in it as and when they want. And it should just be a sustained fixture within the dialysis unit. However, when it comes to sustainability and the cost of an intervention like this, providing it in perpetuity is a bit of an issue. The second finding that relates to what we're doing now in practice is the fact that traditionally these sorts of interventions are delivered by professional artists in residence. In this study, we didn't have a professional artist. We had me, and I am not a professional. I am an amateur at best. But we found that patients were able to engage very well and find numerous benefits in an intervention delivered by someone who wasn't a professional. So we don't need a professional to deliver this intervention. So we came up with this idea of using volunteers because they're far more sustainable and they don't need to have that professional qualification. We were lucky enough to obtain funding from the Economic Social Research Council to develop guidelines on how to actually do this, on how to deliver this intervention using volunteers within a hemodialysis unit. And we are currently in the process of refining that guidance. I think the project comes to an end in April. So that's the most immediate future. In the long-term future, we want to conduct a randomized control trial based on this feasibility study. And this is making it more sustainable in general throughout the UK and throughout the world in terms of having that evidence base there to show that this intervention does work, that there is a causal link between art and improved mental health and well-being. So we are currently developing a proposal for funding to run a multi-site cluster randomized control trial. And hopefully we'll be able to get that funding and establish that it does have a beneficial impact on mental well-being. Linked to that is the fact that as part of the randomized control trial, we need to do an economic evaluation. Now, economic evaluations are essentially how the National Health Service in the UK decide what intervention is going to be funded and what interventions are going to be resourced. So without an economic evaluation, without establishing the fact that this intervention is not only effective and beneficial, but it is worth the costs associated with it, we're not going to be able to provide this as standard on a national scale. So we need to conduct an economic evaluation to make a claim or make a case that these interventions are worth investing in. And hopefully we'll be able to establish that. And that is the summary of my PhD work. Thank you very much. Do I need to hand over to you now, Jeanette?
Thank you for a very nice and interesting presentation, and maybe some strange comments. Also, very nice slides with all these arts on your slides. It was a very good way to get an impression of how you have worked with your patients during your study. Now I will open the question and answer session, and I encouraged all the attendees to ask questions and put your question down in the question and answer box, and then I know Claire will try to answer your question. And the first comment is, thank you, Claire, such a great talk. And
thank you.
I totally agree. When people put their question, I'll start with a question for you, because why did you choose art? You, in the end, just said there could be a lot of other intervention you could have choose to improve mental well-being, but you choose art. Is it because it's a specific interest, or yeah?
So the choice of art was actually based on, as I mentioned, the patient involvement at the start of this study. So that was identified by a patient who used art to cope while they were on hemodialysis in terms of their mental health. But I will say that as a mental health nurse, I've practiced on a few mental health wards, and the provision of art for mental health purposes, not art therapy, just art for art's sake, is standard. Every single mental health ward I've been on has an art room filled with art materials for patients to go to. And it's linked very closely to occupational therapy. So this idea of meaningful activity in a person's life is what a lot of mental health occupational therapists will focus on, as opposed to like the physical issues that come in with occupational therapy. So to me, it seemed like an obvious link. If you're trying to improve mental health and mental well-being for patients on hemodialysis, we should probably use strategies that are used for mental health and mental well-being in patients who have poor mental health and mental well-being. And then personally, I like art, so that was what drew me to the project. Is I do enjoy art. I'm not an artist professionally, but I started drawing as part of the PhD project, because obviously you have to practice what you preach, and I couldn't really teach people how to do art without doing art myself, and I haven't been able to stop. It's very addictive.
Now we have some question for you. You mentioned some about the age, but there is a specific question about the range of the patient age and also the diagnosis. Do you know anything about that?
Yeah, so the patient age, if I can remember off the top of my head, I think the youngest patient I had was 30, and then the oldest was 88. I want to say that was the range. Diagnosis, I'm not sure if you mean mental health diagnoses or kidney disease diagnoses. We didn't capture data on either of those, I don't think. In terms of mental health diagnosis, we weren't screening for mental health. So like I said, this wasn't to treat mental illness. So we weren't excluding people who didn't have depression or anxiety or anything like that. There were a few participants in the study who did have diagnosed mental health issues. So for example, one participant had bipolar disorder, because I know that increases your risk of kidney disease. A few patients had depression, a few patients had anxiety or PTSD, but I think we weren't looking for that. It's just that there's a high prevalence of mental health issues in patients with kidney disease anyway.
Do you have any other data about the patient characteristic and the number of patients who were included in your study?
Yep. So we had 24 patients who were included in the study. That was out of 94 eligible patients. So about 70 refused to take part, which For a feasibility study, that works. But yeah, so we had 24 patients taking part. We had an even split between men and women. And I'm trying to think about what other characteristics would be interesting. Most of them had no prior art experience. I'm trying to think if any did. I think maybe one participant did, but most of them had no prior art experience. Yeah, I'm not sure what other characteristics would be interesting.
There is a follow-up question from the same attendant is asking, are there clinical studies we can refer to?
Yes, there are. So we've published a few articles on this from the PhD. One of them was a realist synthesis. So there are a number of published articles out there that we were able to synthesize. There was an observational study done by Rowe et al. In Florida that looked at quality of life over 6 months on an arts and medicine program, and showed that there was a non-significant improvement in quality of life. Another very good article was conducted by Rowe et al. In 2011. It took place in New York, and it was a qualitative study. And there's some gorgeous quotes in that from participants who describe their experience of flow specifically while on art. And then there's a few, like what we would call grey literature publications, so publications that have been published not through a peer-reviewed article, but through charities and voluntary organizations that provide guidance on how to do this, or provide evaluations on some examples of projects that they've done.
And then there's another asker who said, great talk, congrats, Claire. And you have answered this question, did some patient refuse the art intervention? You have answered that question, but why did they refuse?
So the majority of patients who refused, it was almost an even split. So a lot of patients refused because they weren't interested. They just said they didn't have an interest in art. But an equal amount of people refused because they said they couldn't do it. They said they weren't going to be any good at it, and they were very anxious about it. So there is this barrier there of being really self-conscious about the fact that I'm not going to be good, so I don't want to try. So that's an issue that we need to overcome, definitely.
Okay. And then there's another question. How could volunteers best support this kind of work?
Yep, so we've been doing a lot of workshops and things on this as part of the development of the guidance. And the main finding in terms of how volunteers could best support this is the fact that we need people, not necessarily who are great artists, but people who are friendly, who aren't intimidating, who are open, who are supportive. So that's really the type of volunteer that we need. And that's really what will drive this forward, because while skill development was obviously at the core of this intervention, to ensure that people are able to develop those skills, they need a lot of reassurance, a lot of support, and a lot of positive feedback. So I think that volunteers will be able to best support this by essentially providing encouragement.
Now, I've just once more time, thank you for all these nice questions. It's so good, and I will encourage all the attendees just write question in the question and answer box, so we are able to have a great discussion. And now there's another question. Thank you for a very nice presentation. How did you make sure to include patients from all different social layers?
This is something that I would say is a barrier, not barrier, a limitation of our feasibility study. So this study was conducted at a rural hospital in Northern Ireland. So we don't have the most generalizable patient group in terms of how this would transfer to other countries. So this patient cohort, they were very representative of the geographic area where the study took part, and we approached literally everyone who was eligible to take part in the study. So the only exclusion criteria for participation was that they had to be over the age of 18, which everyone was because it was an adult hemodialysis unit. but also they had to have the capacity to consent. So if they lacked the cognitive capacity to consent to research, this would be less of an issue in practice, but in research, we couldn't include them in the study ethically. So that is really how we included as many people to be as representative as possible, was by making sure that our exclusion criteria were very narrow, that we weren't going to be excluding people for arbitrary reasons. And a lot of that came from patient involvement in the development of the study. So we were querying if we should be restricting participants who had IVFs, or if we should be restricting people who maybe, I can't think of some of the other examples, but there were some reasons why we would maybe want to restrict them. And every time the patients came back and were like, no, give them a chance, see if they want to participate. So by making sure that you're not excluding people on arbitrary reasons or unnecessary clinical reasons, you can make sure that you can include everyone possible. But I would say that the patient group that we recruited from aren't representative of, say, if we wanted to recreate this in London, because it was a very white patient group, it was a very old patient group, and it was, yeah, we're not the most multicultural society in Northern Ireland, so I'm very aware of that. So some of the findings might not translate as well into other settings, but that's something to be mindful of going forward.
And now there's a question about methodology, about methods. What are the qualifications for compelling economic evaluation needed?
So how effective does it need to be in order to qualify as, I don't know if I understand the question. The qualification for compiling.
I understand. You said that I thought when you, I think it was in the complex intervention design, you said you needed to do and in the end you suggest this randomized controlled trial, and then you also said you had to do this economic evaluation. So why do you need to do that, and how would you do it? I think that's.
Yep, no, that makes sense. So why we need to do it is because the National Institute of Clinical Excellence here in the UK, they provide recommendations on healthcare interventions or drugs, anything for healthcare, and they make their recommendations based on whether or not the intervention is effective enough to justify the cost. And there are different ways to measure that. So you can do a cost effectiveness evaluation, which looks at whether or not your intervention, because it is so effective, actually reduced costs elsewhere. You can do a cost benefit analysis, which looks at whether or not the actual outcome, the benefit that you're having, there are specific statistical methods that you can do to compute different measures, but it's weighing that up against the cost with using things like quality adjusted life years, and you have to have a certain amount of quality adjusted life years to justify the recommendation of the intervention. So if we want this to be provided in practice, if we want NICE to recommend these sorts of interventions, or if we want the NHS to commission this, to provide funding or resources for it in the future, we need to show that either it's cost effective, so that will ultimately reduce costs in the long term, or that it's beneficial enough to outweigh the cost by improving mental health and mental well-being so significantly. Yeah.
I'm not sure, maybe you could elaborate this, maybe you have covered this, or you could elaborate it a bit more. Did you experience difference in multicultural setting in approach arts?
I would expect that I would experience a difference, but it wasn't a multicultural setting. It really wasn't. The majority of patients that I worked with had grown up in Northern Ireland. Most of them had grown up in that specific healthcare trust in Northern Ireland. Most of them were older. They were all white. I haven't experienced it in a multicultural setting, but I would expect it to be different. I would expect it to be different because a lot of, not necessarily in terms of the benefit of art, because I would expect that to translate, but maybe the type of engagement, the type of art that people want to do, the type of art that they create, I would expect that would be different because art is so culturally determined. But it would be interesting to see.
Now the next question is if I decided to do the same project art in dialysis patient, what is the important thing that you would suggest us to do?
I would suggest that you essentially involve patients as much as you can ahead of time in terms of ideas for what they might work, but also be very open to patients and make sure that you let patients decide what their limits and what their restrictions are, because they usually have fewer limits and fewer restrictions than you assume that they will have. I wouldn't write anyone off because of any sort of clinical issues. You know, if they're very unwell, they still might want to participate. If they, for example, I worked with a participant who was on dialysis but also had hemiplegia, so they were paralyzed down one side of their body. They still participated in the full 6 sessions. I would just say, don't write anyone off and let people decide what they are capable of and let them try things out. Yeah, I think that's the biggest piece. That's the biggest thing that I learned providing this. But yeah, involve patients during the design as well, because one of the reasons our project was so successful was having that patient and healthcare professional input. We identified all of those practical issues ahead of time, so we went in ready. So I'd recommend that as well.
Could you elaborate this patient involvement you had in your project, but also the involvement of the clinician? How many times? How did you involve them, and what did you do?
Yep. So the development of the intervention involved a few steps that included patient and healthcare professional involvement. So, for example, we had an advisory group set up that included 3 patient representatives, a nurse representative, a consultant representative, a few artists and residents, and a few academics who advised and identified a lot of the barriers that we might encounter and how to overcome those barriers. But as part of the development, I also visited hemodialysis units and spoke to the healthcare professionals on those units, spoke to the patients on those units to see what they thought about this idea of doing art and dialysis, if there was any way to make it more appealing to them or anything that we needed to take into consideration. Another thing that I was able to do was, as I mentioned, there are Arts Care Northern Ireland provide arts to hemodialysis units here. So I was able to shadow an artist in residence who was providing art in Belfast City Hospital's hemodialysis unit. And that gave me an opportunity not only to see how they delivered it, but it also meant that I could speak to patients who didn't want to take part to find out why they didn't want to take part and if there was anything I could improve on to make it more interesting to everyone. So yeah, there was lots of different ways.
So the patient were involved in designing your intervention, but they were not a part of your research team?
No, the patients on the advisory group were a part of the research team. They're named on the publications.
Yeah. Pressing. And then there's a question here. Did you use the Stepwedge method to test the impact of the intervention on the patient?
No, we did not. That's actually quite an interesting question, because we're designing the proposal at the moment for the definitive trial. We used a cluster randomized controlled trial design for this pilot study, which worked okay. We clustered by, so a cluster randomized controlled trial, for anyone who doesn't know, is whenever you split people, you randomize according to group as opposed to individual. So we randomly allocated the morning shift to the control group, and then the PM shift, so the afternoon and the evening shift, to the intervention group. So all the participants in those shifts got the intervention. And that worked. We ended up with the same amount of participants in each arm, but we found that the participants in the control group, so in the morning shift, were a lot more unwell, and they were their mental health measures were a lot lower. So they weren't the same at baseline, which is an issue in trial design. So we had to figure out a way to get around that. So now we're thinking that we're going to randomize according to shift at multiple sites to control for the issue of the difference in shifts. But we are thinking about whether a Stepwedge method might be better, because then people get to be their own control group. But we haven't decided yet. We're thinking about it.
Perhaps some of the attendants do not all know what a Stepwedge design is. Could you say some more words about what is a Stepwedge design?
So I haven't carried out a Stepwedge design, so I don't know it as well as the cluster design, just to say that. But essentially, a Stepwedge design is when every site that you recruit takes part in the intervention. So every site will take part in the intervention. It's different what time they take part in the intervention. So you'll recruit the site into the study, and either maybe they will start the intervention immediately, or you'll collect some outcome measures and they'll start the intervention 3 weeks down the line, or 6 weeks down the line, or 10 weeks down the line. And then you have this 6 week, 10 week baseline data that you can compare to their post-intervention data. It's both slightly more complicated and also more straightforward than a cluster design. Yeah, so it's a way of essentially letting everyone take part in the intervention, which is something that ethically we had to do anyway. But you can still collect data, which you couldn't do in a waiting list design. So it might be a more resource efficient way for us to provide or to conduct the definitive trial. So it's just a different type of methodology, slightly different methodology.
Now I have some other question for you. Can I please ask, what visual art activities did you facilitate within your study with the patient?
Yep. So we had a variety of different materials that they could use. Each pack contained fine liner pens, graphite pencils, watercolor paint, and coloring pencils. So they could do any of those, they could use any of those materials. Now, in terms of drawing, that seems to be the thing that most people were anxious about. And when people were too anxious to draw, what they would ask would be that I would like sketch something for them, and then they would use the colored pencils or the paint to complete the picture. And I did try to encourage people to draw, because I understand that people are anxious about that, but people can do it just as long as they know how to. They just need to be told how. But anyway, so there was a lot of people used the watercolor paints. That seemed to be the easiest material for people to use, especially people with an AVF, because they only had that one-handed thing. So dexterity it's not too important with watercolor because it's a wash. But a lot of people did draw, and a lot of people did use colored pencils. Not a lot of people took part in the creative writing activities, though. I think only maybe 2 participants wanted to do poetry, and then for most of the sessions they still wanted to do visual art. So visual art was definitely the most popular, and then watercolor painting was the most popular type of visual art.
Then there's a question here. Is it possible to implicate art to the practice as obligatory to the HD patient, because it's very useful activities?
Sorry, can you repeat that question?
Yes. Is it possible to implicate art to the practice as obligatory to the HD patient, because it's very useful activities?
So does that mean like compulsory?
Yeah, or mandatory or something like.
Yeah.
I think.
I mean, I wouldn't say that we should be making art mandatory, just because I'm very reluctant to tell a patient that they have to do something, especially something like art, which is intended to be enjoyable and not prescriptive. I would believe that it would benefit everyone if they gave it a shot. But
I think it's not mandatory, it's obligatory. The answer asked. I'm not sure of the English word, I'm sorry.
Obligatory? I thought
Yeah.
obligatory. If it's an obligation, is it not mandatory?
I don't know.
I don't know if I'm misunderstanding the question.
Okay.
If you
Then
could
we take
rephrase-
another question. Did you find timing of the day had an effect on the patient engagement?
No, not really in terms of engagement. I did find that we had really good engagement, so it's very hard to compare because every participant engaged very well. Every participant completed the full 6 sessions of the intervention, and they all wanted more. So we didn't have any issues of low engagement. I would say that the patients in the afternoon shift were very unwell compared to the patients in the twilight shifts, in terms of like their physical health. So for example, the participant who kept falling asleep, who had fantastic engagement, by the way, she engaged very well. It was just, she needed to be woken up. She was in the afternoon, and I think that's just because of how the unit structured their patient, their people who attended in the afternoon shift tended to be older and they tended to be more unwell. But we had fantastic engagement all across shifts. Yeah, it's just that maybe the participants in the afternoon shift they needed more practical help, and that was the only difference.
Then it's another one. So thanks for this very interesting talk. Are you planning to use quantitative methods to measure the patient perception of time during hemodialysis?
We're not planning to at the moment, but there is a quantitative measure. There's no validated quantitative measure that I know of that measures perception of time, but there is an observational measure for flow states. So you can actually quantify the level to which a person is in a flow state. And that is something that I've been looking into, but I'm not sure if we will, because that requires someone to be there watching while the person's doing the art. And I find that might be a bit off-putting. But yeah, if there was a measure of perception of time, we would be keen to use it. I know that there's a social worker who's a member of the renal arts group who's been looking into that in terms of whether there's a way that they can develop a measure of perception of time for a quality improvement program that they were working on, but I don't think they ever got round to developing it. If anyone has an idea for a measure of perception of time, that would be great, but I'm not familiar with any.
What will you go to? What will your primary outcome be at the randomized controlled trial?
So the primary outcome that we're hoping to use is the Warwick Edinburgh Mental Wellbeing Scale. So that is directly linked to that PERMA construct. So it measures all those 5 components. So yeah, it hasn't been used extensively in patients receiving hemodialysis, but it has been used a lot to measure the impact of art. So I think that's our primary outcome. We are going to be measuring mental health outcomes. So we want to be measuring depression and anxiety using the PHQ-9 and the GAD-7 as secondary outcome measures, but the thing that we're expecting to impact on is mental well-being.
And so there's a question here. What did you do with completed art, and did you share to motivate others?
Yes, so we let the participants keep their own original art for the most part. Every participant got to keep all of the materials that they got, but I did take photographs of it and make it into prints so that I have copies of it and they have copies, they have the original. So what we've done with it has mostly been display. So we had an exhibition both back when we could have in-person events. We had an exhibition at as part of the Economic and Social Research Council Festival of Social Science here in 2019. And then we've displayed them for the UK Kidney Week. They've had a few arts exhibits for their conferences. So we did one this year. It was a virtual one. I can't remember if we managed to display them last year. I don't think I had the prints made by then. So yeah, so we've been using it as a way, I think, to show, well, to evidence the fact that people on dialysis can paint and draw, but also to raise awareness of this sort of work. We didn't have any completed art at the time of recruitment to motivate people to take part, but that is a strategy that we're hoping to use in the definitive trial. because I think that can help reduce anxiety. If you can see what other people have done, you will maybe think that you can do something similar. So that's the plan.
I just see if there are any more questions left, but then I will have one last question. Could you sum up what you haven't done this randomized control trial? We do not know if it's effective, the effectiveness of this intervention, but what should the main argument to be why to do this in our unit or where we are and have the opportunity to implement this intervention? Why should we do it?
Why should you do it? I think because time on dialysis is a huge issue. Like, it is a huge negative issue for patients on dialysis that it's easy to dismiss. It's easy to say, oh, it's trivial, they're just bored, but I mean, it's relentless. And I think that just addressing that on its own is a huge benefit. Even if we can't measure the effect of mental well-being, that is a huge benefit.
Then I want to say thank you to you one more time for your speak here today, to learning about us, about art and how we can promote well-being among our patients. Also want to thank you all the attendees. Thank you for listening here today. Thank you for asking all these questions. And then I want to inform you about the next webinar, which is about green excellence, where a panel will discuss what is green excellence in our setting. So thank you all, and also thank you to the EDTNA, ERCA for organizing such webinar. Thank you so much, and have a nice day.